This slide set addresses Chapter 26 in the Loudermilk textbook, which is entitled Antepartum Testing and Fetal Assessment. Some of the assessments that are contained in this slide set are routinely offered to all patients because any pregnancy can be screened using these tests for problems that impact both the mother and or the fetus. Again, this is done at different times throughout the pregnancy and can be part of routine screening, or it might be ordered in situations where there are known issues such as genetic disorders, nutrition or health concerns of the mother, including some of those pre-pregnancy issues like diabetes, hypertension, or other medical conditions. And then also whenever there are known issues with the pregnancy, both in the current pregnancy and historically. Antepartum testing can also be utilized for psychosocial concerns in the mother. These can include issues with domestic violence, substance use, psychiatric concerns, or sometimes any sort of emotional distress that may impact the health and well-being of the patient and pregnancy. Oftentimes, patients are brought in on a more frequent basis during routine prenatal care to make sure that we are touching bases with them, being able to adequately assess mom's psychosocial state of mind, her progression into perinatal mood disorders, or issues that may harm the pregnancy or fetus, depending on the circumstance. The majority of these include our lack of prenatal care patients. The sooner we can get a patient into care, the more continuity that we have and the more likelihood of identifying high-risk factors. Lastly, environmental factors may influence the outcome of pregnancy. For patients that are exposed to chemicals, anesthetic gases, radiation, or other hazards in the workplace, we need to be proactive in addressing those concerns throughout the pregnancy in order to make the pregnancy and work environment as stable as possible. For example, for nurses, as long as we are adhering to our standard precautions, universal precautions, and taking care of ourselves during pregnancy with personal protective equipment, there's not a lot of issues that you cannot interact with in nursing. They may limit your exposure to chemotherapy agents or radiation. However, the routine nursing care that you provide on the floor oftentimes is fine during pregnancy. One of the earliest screening tests that we can do is the AFP, or alpha-fetoprotein. This is a chemical that is released by the fetus if there are neural tube defects present. It diffuses back through the placenta and is then identified in the mother's blood tests. Neural tube defects can include any sort of defect of the central nervous system, such as spina bifida, where you have an open spine. Also, if you have anencephaly, where the brain does not develop. A more thorough screen is the triple screen, and that is an alpha-fetoprotein test to test for neural tube defects, an HCG level to make sure that the placenta and the pregnancy is advancing as expected, and estriol, which is a type of estrogen. The triple screen is very sensitive in identifying Down syndrome, but remember that this is only a screening test. Other things may be impacting the pregnancy beyond Down syndrome if you have an elevated triple screen. To determine the dating of the pregnancy, this will give us an estimate of how far along the pregnancy is using the crown to rump length. This will take a measurement from the head of the baby down to the rump or the buttocks of the baby. And at this point in the pregnancy, all babies, regardless of genetics, are going to be about the same length. So the ultrasound machine has calculations inside of the machine itself to determine how far along the pregnancy is based on the millimeters of the crown rump length. Once the pregnancy gets a little further along, we can measure the biparietal diameter. This will allow us to measure the head circumference by looking at the parietal bones both sideways and front to back. You'll be able to visualize heart motion at about 6 weeks of gestation, even though it is present a lot earlier than that. The dating of the pregnancy is most accurate in the first trimester and is often used whenever mom is unsure of her LMP. Pictured here is the abdominal ultrasound. If we are looking at structures earlier in the pregnancy, they can do a transvaginal ultrasound where a probe is covered with a condom and placed inside the vagina to allow us to really see structures that are forming early in the pregnancy, or the transvaginal is used oftentimes to measure the length of the cervix. We use ultrasound throughout the pregnancy to establish or evaluate fetal heart rate, gestational age, making sure that fetal growth continues, as well as looking at fetal anatomy. If we're looking at fetal anatomy, that's usually done between 18 and 20 weeks of gestation. Anything prior to that, you won't be able to see the granular detail that you need to determine that the anatomy is appropriate. The head circumference and the abdominal circumference, which is seen in the ultrasound picture to the right, is how we're going to use additional parameters in order to determine fetal growth. Again, babies up to about 20 to 24 weeks grow at a set rate regardless of genetic background. Whether you have tall parents or short parents, you're about the same size as a fetus at that gestational age. So taking all those parameters into account, the ultrasound will be able to calculate a due date based on crown to rump length, head circumference, abdominal circumference, and biparietal diameter, as we've previously discussed. To other invasive tests, which we'll go through in a few minutes. This is used to identify the amount of fluid that is in the amniotic sac, and to determine locations of the placenta, the umbilical cord, and in cases where we're doing further testing, the location of the needle where it's going to be placed. We can also look for fetal well-being with amniotic fluid volume. We can measure the relative amount of amniotic fluid in the amniotic sac. Remember that well-oxygenated fetuses will have adequate urine output, and the majority of urine is, the majority of amniotic fluid is made up of fetal urine. This is a good picture of the colored Doppler technology that's used that will show us both the umbilical artery and vein, where it shows the blue deoxygenated blood and the red oxygenated blood. And then on the right-hand side, that shows the actual fetal heartbeat. So it'll allow us to determine if there are problems with the strength of the cardiac output. Sampling. This is an invasive test, and it's performed usually transabdominally. This allows us to take a tissue sample from the fetal side of the placenta. If you remember, the chorionic villus is what's going to help with the diffusion of blood throughout the placenta, and we're going to take a tissue sample from that chorionic villi, usually between 10 and 12 weeks of gestation. This will allow us to screen the genetics for chromosomal defects early enough in the pregnancy, so if the mother chooses to terminate the pregnancy, she still has the opportunity to do so. The concern becomes, because we are doing this so early in the pregnancy, if there were problems that were identified, there is nothing we can do for it. So as you look at the list of complications, miscarriage, premature rupture of membranes, infection, all of those could pretty much doom the pregnancy to termination if there are problems. To perform CVS testing, the physician will take a 20 cc syringe and a spinal needle, which is about 4 to 5 inches in length. They will go ahead and identify the specific location in the placenta that they're going to withdraw from, and by ultrasound guidance, watch the needle puncture through the amniotic sac, and then identify that specific area of the chorionic villus to then send to the lab. The CVS, you see that you are guided by an ultrasound both transvaginally and transabdominally. A little bit later in pregnancy, we can do percutaneous umbilical blood sampling, also known as PUBS or chordocentesis. This is also done with ultrasound guidance. It allows us to put a spinal needle directly into the umbilical cord and withdraw blood from the fetus. This will allow us, first off, to perform genetic testing on the fetus. We would be able to determine ABO incompatibilities. And this would allow us also then to do any sort of blood transfusions that you may need to do. This slide shows chordocentesis, again performed under ultrasound guidance. The examiner finds a good place on the umbilical cord to be able to insert a needle and then be able to withdraw blood directly from the umbilical cord, and in certain cases of blood transfusion, be able to insert blood back into the umbilical cord. Most of the time, patients undergoing this procedure are sent to a high-risk center, usually in the Bay Area. This procedure is not usually done in the Fresno area. Amniocentesis is done usually between 14 and 18 weeks. During this process, an ultrasound is performed, to identify where a pocket of amniotic fluid is. During this process, a spinal needle is then inserted into the pocket of amniotic fluid, and the fluid is withdrawn. At the 14 to 18 week gestation, we will be testing for genetic disorders. And then later in life, closer to the late third trimester, we will be assessing pulmonary maturity. With this, we would use the LS ratio that we talked about earlier in class. And for a normal pregnancy, an LS ratio of 2 to 1 means that the lungs are mature, and we can go ahead and proceed to deliver that patient electively if needed. Again, the complications for CVS testing, PUBS, and amniocentesis are all the same. The complications are rare, but again, because we are doing this testing so early in pregnancy, if there were complications, there is nothing that can be done to save the pregnancy. You'll have an ultrasound that identifies the pocket of fluid, and then the fluid is then withdrawn, and you can see that you have a nice clear amniotic fluid in the syringe on letter B. The nurse is integral in the antepartum testing environment, specifically because they are, in most cases, performing these tests, mainly the non-stress test, contraction stress test, and biophysical profile, which we'll get to in a few seconds, but also as an assistant to the provider who's performing amniocentesis, CVS, and ultrasound. Nurses can be trained on some components of ultrasound. So in some clinics, nurses are the only providers that see the patients, with physicians reviewing both the ultrasound result and non-stress test in a later date. Keep in mind that being addressed or being diagnosed with a high-risk pregnancy can be very stressful, because obviously whenever a woman becomes pregnant, she believes that her baby will be perfect and that she will have the perfect pregnancy. And issues with high-risk pregnancies does increase the anxiety level for the patient. While up to this point we've talked about higher risk testing, what we want to ensure is that all pregnancies are evaluated for fetal well-being. A lot of antepartum deaths or stillbirths will occur in patients that have no known risk factors. So we need to identify an ideal test which allows intervention before there are problems with fetal asphyxia, abnormal acid-base balances, and be able to identify those patients at risk. The main issue that we are looking for in tests of fetal well-being is uteroplacental insufficiency. This is a circumstance where there is inadequate delivery of oxygen to the fetus. Oftentimes during this testing, you'll see late decelerations or other indications of inadequate blood flow, including minimal or absent variability, and you will be able to identify this very easily on the fetal monitor. There are a lot of conditions, like we talked about in class, that put the fetus at risk for uteroplacental insufficiency, and some of them are listed here. The different methods for testing the fetus are listed here from least invasive to most invasive. And obviously, fetal movement counting is a universal way to address some of the concerns to assess for uteroplacental insufficiency. A baby that is acidotic will not move. With fetal movement counting, mom's perception of a decrease in fetal movements may be a sign that the baby is not getting oxygenated well. It's very easy. Moms can do this anywhere and be able to have a very low risk, non-invasive method to ensure that my infant is safe. There are many different methodologies of fetal movement counting. However, the most important is, first off, that the mother is performing fetal movement counting and there is a universal agreement within a specific hospital or group of physicians of how you're going to provide instructions to the mother. For example, utilizing the 10 movements in 2 hours, the instructions to the mother would be every morning whenever you wake up, pay attention to your baby, and once the baby moves 10 times within a 2-hour period, you're fine. That shows that the baby is well oxygenated and moving well. And you can stop once you have achieved the 10 movements in the 2-hour period. If it takes 5 minutes to achieve 10 movements, great, you're done for the day and your baby is well oxygenated. If it takes longer than 2 hours to achieve that 10 movements, you'll need to call your doctor, potentially drink some cold water, lay down and try again. And if after that second period of time you don't achieve 10 movements, you need to be seen in labor and delivery. Non-stress testing is done in the late second or early third trimester in order to monitor fetuses at risk for lack of oxygenation. Remember, every time that you perform fetal monitoring, you need to apply both an external ultrasound and a tocodynamometer to be able to evaluate fetal heart rates in relationship to contractions. If we have accelerations of the fetal heart rate in response to fetal movement, you can know that the central nervous system is well oxygenated. Fetal heart rate accelerations are what we are expecting on a non-stress test. If we do not have adequate fetal heart rate accelerations, we can assume that the baby is hypoxic during a fetal sleep cycle or otherwise compromised. We need to ensure that there are accelerations of the heart rate at least by 15 beats above the baseline, lasting for 15 seconds, and we need to have that happen twice in a 20-minute period. If you are less than 32 weeks of gestation, we need to monitor for 20 minutes, and acceptable accelerations would be 10 beats above the baseline by 10 seconds. To perform the NST, we place the external ultrasound and tocodynamometer. We put mom in a maternal position of comfort or a left lateral tilt to help minimize supine hypotension. And in the majority of times, the fetal movement is recorded by mom pushing a button on the fetal heart rate monitor if she feels movement, or some monitors will actually monitor that movement independently. The heart rate at least 15 beats by 15 seconds. That is termed a reactive NST. Sorry about that. A reactive NST means that the baby is well oxygenated and the mother can return home. A non-reactive NST occurs whenever you have less than 2 accelerations in 20 minutes, or if the accelerations do not reach that 15 beats above the baseline by 15-second time period. We can continue the NST for up to 40 minutes, and if the baby is still not reactive at that point in time, we move on to additional tests. The next test that we can use to evaluate the infant is a biophysical profile. This uses ultrasound to evaluate fetal well-being using 5 parameters listed. The non-stress test is one of them, and they are always performed with a BPP. Each component and the BPP gets scored all or nothing. So you get a score of 2. For example, if you end up with 3 body or limb movements within 30 minutes, or you don't have any score at all if you don't reach that 3 body or limb movements within that 30-minute time period. Even if you get 2 movements, you still get a score of 0. So obviously, the higher the score, the better oxygenated and the healthier your fetus is. If a patient has a score of 8 or 10, that's considered normal. The patient can be sent home and return in 2 to 3 days for further evaluation or repeat in the non-stress test. If the score is 6, or if the patient has a low amniotic fluid volume, termed oligohydramnios, the patient should be delivered regardless of gestational age. So the patient will undergo induction. If we are scoring between 2 to 4 or even 0 points, most of the time that suggests chronic asphyxia in the fetus, and most of the time those patients are admitted to the hospital for delivery. Again, we look at the health of the pregnancy And if the fetus is not oxygenated, even at an early gestation, sometimes those fetuses do better in a nursery where we can provide adequate oxygen for them. Contraction stress test. This assesses the fetal central nervous system with heart rate changes in response to contractions. So if you have a fetus that is hypoxic, they will have late decelerations on the fetal monitor. The more late decelerations the patient has, they correlate with stillbirth, growth restriction, and low APGAR scores. There are two ways to induce a contraction stress test. The first being an oxytocin challenge test. That is where an IV is started in the patient's arm. The patient is given IV oxytocin to stimulate labor, and the patient is evaluated after she has 3 contractions in 10 minutes. The other method to start a contraction stress test is using nipple stimulation. Again, the patient will stimulate her own nipples or have her partner stimulate the nipples in order to release oxytocin. That in turn will cause contractions of the uterus, and nipple stimulation is continued until you have 3 contractions in 10 minutes. Labor and delivery, we're going to place the fetal monitors, and then the patient will be given informed consent. Contraction stress tests are only performed if it will be safe for the patient to deliver vaginally. So, for example, the patients with contraindications for a vaginal birth, active herpes, HIV, placenta previa, classical C-sections, all of those patients, any patient that you don't want to deliver vaginally should not have a contraction stress test. Because again, we assume that we'll be able to stop our contractions from occurring, but you can't always assume that. After we achieve 3 contractions in 10 minutes, we'll interpret the contraction stress test. A negative CST means that there's no late decelerations in that time period. If we have a positive CST, that means that we have late decelerations present with the majority of the contractions. That means if we have 3 contractions in 10 minutes, you should have late decelerations with 2 of those. If the CST is negative, the patient is considered safe to be discharged. At that point in time, we'll turn off the oxytocin infusion, and then we will wait for the contractions to resolve before the patient is sent home. If the patient has a positive CST, and in this case a positive is not a good thing, the patient is often continued in labor, and the patient is then delivered. But this is a more thorough list to those.